Okay, fine. As you told, this is acute viral encephalitis, epidemiology and diagnosis. What I thought is many times this diagnosis is not very concrete and we depend upon many other things. So we need some interpretation with regards to what have the laboratory investigation are performing. That's why I thought to keep some view on the programmatic aspects of viral encephalitis, what's our epidemiology, and what is the diagnostic approaches we look into. Next slide. So if you go by standard definitions of different terms, we use many terms like encephalitis, encephalopathy, meningitis, myelitis, or reticulitis like that. These are sometimes we say meningoencephalitis in combination also. So in isolation, we may not get a very pure case of encephalitis or meningoencephalitis in combination. So we can think of. So different terminologies are there, but we are very cautious of it. We know what to do and how we are approaching or diagnosing a case of encephalitis or encephalopathy. I will just give some differences in this line. Next slide. If you look into this picture, these differences in the encephalitis and encephalopathy, we know that both the presentations can be very similar, but the differences likely is this encephalitis produces inflammation. It does give the changes in the CSF in form of inflammatory cells rise or protein is high like that, but encephalopathy doesn't give rise to that. But beside that, in clinically, if you look into fever, headache, vomiting, all fever and headache, all these inflammatory markers or responses of infection are not seen in a classical case of encephalopathy. So while looking into a case, we very well look into whether we are dealing with infective origin or some other causes like metabolic or some other component that causes encephalopathy like presentation. So for reaching the diagnosis, we initially try to exclude whatever any form of encephalopathy so that the classic cases of acute encephalitis will be entering into so that our diagnosis or efficacy of diagnosis will be proper. Next slide. So if you look into classic cases of acute encephalitis, it's broadly as a part of program definition, we say this is acute encephalitis syndrome or acute encephalitis syndrome or AES. So don't very well say this is acute viral encephalitis or so because under this banner many things are there. So the etiology may be different. It can be viral or like infective or non-infective causes also. So the most common causes what we are dealing is viral infections are as a coming as a major issue, but otherwise bacteria also can cause depending upon the different geographical setting or different host factors or climatic associations. It may differ as per the time to time, but whatever situation it may be in India currently or as of now, JE becomes a one of the major causes of encephalitis, especially in terms of outbreaks or epidemics potential. But if you look into endemic viruses or endemic viral infections, such as scattered cases of hospital infections or hospital admissions, they mostly account for HSV or influenza, or it can be West Nile also, Chandipura also, dengue, measles, other enteroviruses, or these viruses can come up with the second alternative for mostly in case of sporadic settings. Next slide. But some etiology, some emerging viral infections are coming up, like human parvovirus, parvovirus infections. West Nile is coming. Mostly it is restricted to northeastern part, maybe some part of West Bengal. Bagaja virus I have never encountered this thing. Coxsackie virus is also coming up in a simple form of HFMD or some enteroviruses, which causes HFMD also that can cause encephalitis, which is also becoming growing concern, especially in the Western world, though not in our setup. It may be because of misdiagnosis or some other factors, but still we feel Coxsackie virus or other enteroviruses are causing a growing concern of emerging viral agent for acute encephalitis. Next slide. I won't go much detail. You can skip this slide. Next slide. You can move. Okay. If you look into the pathogenesis, how does it cause, and that will help you in some understanding this. Normally, most of the viruses are hematogenously spread or through some mosquito bite or some other infection. It spreads by hemogenous route, and direct viral destruction can be one of the mechanisms. That means a cytopathic effect of the neuronal cells or brain parenchymal cells. That also can be a possibility. Or otherwise, two things can be a possibility: either para-infectious or post-infectious inflammatory response. That is mostly immune-mediated damage or immune-mediated response. So it can be simultaneous with the infection, or it can be post-infectious origin. Primarily, it can infect the brain parenchyma and neuronal cells. Most of the virus it causes, what cytopathic effect and also the immunological responses both are responsible. Sometimes it can cause presentation like vasculitis, and demyelination normally follows an infection. It's not very immediate. It can occur afterwards. Next slide. If you look into AS as a public health concern, as I told from the beginning, we go with a very broad definition of acute encephalitis syndrome under a broad banner. WHO or our country NVDCP or National Counter for Disease Control Program defines a term called acute encephalitis syndrome to cover largely many of the possibilities under a broad banner, and which definitely is a major public health problem worldwide because of its high morbidity and mortality. Even if it may depend upon the morbidity is high, also mortality is also very high. That's why even sometimes you can say that the number is less, but looking into the morbidity and mortality, it carries a great concern. Incidence of AS definitely varies from time to time or from different geographical situations. It may vary from 3 to 5 or 7 to 7 to 8 or 7.4 per lakh patient years. It is higher in children below 1 year, also in elderly population more than 60 or 65 years age group. Next slide. Next. Next slide, please. So classically, okay, just keep the previous slide. Okay. As for the program definition, if you look into acute encephalitis syndrome, the case definition has been laid down as a suspected case having acute onset of fever within 4 to 5 days or 5 to 7 days with an altered sensorium, that is change in mental status, with or without a seizure. Normally that is of fast onset, not having a previous history, and other early clinical findings of mental disturbances or deterioration in form of irritability or somnolence or abnormal behavior, which is not proportionate to the normal observations or normal scenario of a child or a person. So, if you look into this is acute onset fever plus some degree of mental status deterioration with or without seizure. So, we should have two components to fit to say that this is a case of acute encephalitis syndrome, irrespective of the cause. What do we think? Next one. Next slide. If you proceed for that, ultimately we have to say that whether this is a case of acute viral encephalitis or not, then we need to go for a diagnosis, but many times laboratory confirmation is not always possible. Still, if we go with a laboratory confirmation, we have to put for different investigations like antigen antibody assessment or a direct PCR assay for diagnosis of DNA or RNA from the respective virus. So we can use a CSF sample or a serum sample, most of the cases. If you are getting a very confirmation of IgM antibody in the serum and or CSF to a specific virus, or there is a paired serum or in the paired sample, if you are getting IgG titer rise, or a viral isolation from the brain tissue, or antigen detection, or a PCR positivity. These are the clues when if you get anything in correlation or in association with the clinical symptomatology that is exactly fitting into acute encephalitis, we say this is a laboratory confirmed case. Next slide. Then sometimes we are confused with whether should we test for a serum to depend upon a serum marker, or should we depend upon the CSF findings, or should we depend upon a PCR findings, like that. Just let me say what are the problems in it. Actually, majority cases of if you look for a diagnosis from CSF, searching for a RNA or DNA, many times you don't get it, means either it will become a PCR negative in spite of a broad range of investigations, including multiplexing, any other aspect. Many times you don't get it. This cause may be that we are dealing a case little bit late, or viremia is not that very high, or sometimes to come to a detectable level, or sometimes RNA viruses itself pose a challenge of diagnosis. So many times we miss a diagnosis if we only depend upon a CSF PCR or CSF RT-PCR assay. So sometimes you have to depend upon the CSF IgM antibody rise or antibody presence. If that is at least IgM positivity from the CSF or a PCR in the CSF you are getting, we say definitely this is positive. If not, we depend upon a serum IgM value and with a clinical correlation of the case specific to the virus. So if you are getting that, we say that this is a laboratory confirmation case. But sometimes in case of the outbreak setting or setting where all these investigations are not possible, then we have to depend upon some definitions like probable case. A probable case we say if in a outbreak setting or epidemic setting, there is a temporal relationship to a confirmed case and nearby zone there are other cases are there and it is fitting into a case of AES clinically, then we say this is a probable case if not able to be diagnosed. And with investigations, if you are not getting a viral cause, you can say that this cause is some other cause, it's not viral, but some other cause we are identifying. And the case may so happen that we are not getting anything. So we say that this is a case of acute encephalitis without a cause or unknown cause or unknown etiology. Next one. Next slide. So everybody know that clinical manifestations are of acute encephalitis starts after a short incubation period, most of the times 4 to 5 days or 5 to 7 days or 10 days maximum. Following many of the viruses like maybe JE or dengue or measles, all these infections can cause encephalitis after a short incubation period. And they can present with fever, altered sensorium, or a seizure, or signs of raised ICP or raised intercalated tension. And sometimes you can get localizing symptoms or signs in form of deficits. Next slide. I will skip this also because everybody knows what are the race features of ICP, but sometimes in case of small children, we may get little differences. We can get some subtle signs. We may not get very florid pictures of raised ICP, but we have to have a very stronger suspicion to say that there is some degree of uh, raised ICP features are there. It can include extreme irritability or excessive crying on not consolable or not consolable cry, increased sleepiness. Sometimes only feature can be shrill or high pitched cry, nausea, vomiting, headache or neck stiffness, which are classical, convulsions or some focal neural deficits. And it can be, you can see the tense fontanelle or pulsating interfontanelle, neck stiffness, eye deviations, pupillary changes, and vital parameter changes, posturing or irregular breathing pattern or papillary edema. All these can be either isolated or a combination of presentations. Next slide. We can get some clue towards what type of viruses it can cause. Suppose encephalitis is associated with GIT symptoms. It can be because of enteroviruses or rotaviruses or poricoviruses. This can have a feature like loose motion or pain abdomen or some loose motion vomiting can be more dominant in these cases. Next slide. And respiratory illnesses like influenza or paramyxoviruses or some bacterial infections can have a dominant respiratory symptoms to say that, and along with the features of pneumonia or lower respiratory illness, we are getting features of encephalitis also. That gives a clue that what type of viruses can be possible. Next slide. Next slide. Here we can get some clues from the type of presentations and what type of virus it can be. Many times, if infection is because of herpes simplex virus, we can get focal encephalitis, mostly involving the frontotemporal zone, especially in the young children. And sometimes herpes labialis can be a possibility because of recurrence of herpes labialis that can have a latent infection, can exacerbate, it can cause encephalitis also. And in case of varicella zoster, we can get cerebral ataxia as a feature. Extrapyramidal manifestations can be seen in case of Japanese encephalitis, rotational virus, or Nipah virus, or sometimes in case of autoimmune encephalitis also. Retinitis in case of CMV, and rashes can be possible in case of CMV, West Nile, measles, rubella, varicella zoster also, Coxsackie or enter group, which cause simultaneously, as I told, hand, foot, and mouth disease at HFMD. This is a prone season for that also. And diarrhea we can get in case of enteroviruses, respiratory illnesses, as I already told, influenza H1N1 or other viral infections that cause simultaneously respiratory infection. Worms can cause parotitis or arthritis simultaneously. And lymphadenopathy can be a feature of HIV or FN virus or CMV, rubella, mumps like presentation. Hepatitis can be possibility in case of or hepatic enzyme elevations we can see in case of CMV or enteroviruses. Okay, next slide. From this, at least we can get what I mean to say is we can get certain clues to approach what type of diagnosis or what type of virus it can be possible. That helps in sometimes prioritizing the viruses we are going to screen for. If you have a sufficient, if you don't have sufficient number of or test kits, or we don't have sufficient sample to be processed for with many viruses, and we don't have a multiplex PCR option. So sometimes we have to think of which can be the highest possibility, and according looking into the clinical signs and symptoms or local epidemiology, we need to say that this can be the first priority. Let's think for India, we are thinking as a the first priority, second can be SSP, like that. We can proceed our plan of investigation. Then we'll look into some of the epidemiology of the country, or especially I'll focus on the regional epidemiology of our Odisha and nearby regions. We say that acute viral encephalitis is a public health concern worldwide, only, mostly because it's having high morbidity and high mortality and a difficulty to diagnose. And incidence I already have told 5 to 10 for 1 lakh patient years. And it's most common in children, elderly, more than 60 or 65. Slight predominance in males, we don't know because of why it is so. Maybe exposure is more to vector population or outside behavior. It may be because of that male are more prevalent. And mostly it is more common in June to September, maybe because of arboviral illnesses or uh, because of mosquito or arboviral illnesses that can be more prone in June to September or September to October period. The incubation period is not fixed; it will depend upon the different viruses, but roughly it is 4 to 5 days, 4 to 6 days. Next slide. If uh, if you look into, I have tried to list different outbreaks here. JE outbreak is not there because JE is coming here and there most of the times, so I didn't include that. Besides JE, if you look into the different outbreaks and different settings, mostly the region covered by Eastern Ghat belt, starting from Karnataka, uh, Andhra Pradesh, Odisha, or Maharashtra, some part of Maharashtra, or Bihar, Madhya, all these regions are being affected with different types of viral encephalitis. And sometimes also we remain with a no identification of the cause etiology. That remains always a challenge for us. But almost many times the outbreaks are occurring in this country, time and again, with a diagnosis or without a diagnosis. Next slide. Next slide. I'll try to give some of the impressions on what type of viral encephalitis cases we are encountering in the region. This, as I told, Chandipura virus, just I will start with a infection that is called Chandipura virus encephalitis. I want to stress upon this first time because uh, largely it is not noticeable many parts, and we usually miss this diagnosis. Because if you look into the clinical presentation or epidemiology of outbreak of Chandipura encephalitis, mostly it affects young children or children to adolescents or little young adults. And in this case, the mortality rate or time to cause death from the first onset of symptoms is very minimal. That means within a 12 hours time, 24 hours up to 36 hours, the death can happen from the first onset of seizure or first onset of altered sensorium. So the majority of outbreaks, whatever occurs in the hilly regions, either almost they remain undiagnosed because the mortality is very fast and it doesn't spread too much. Either it causes 20, 30 cases or 40 cases, max are 50, 60 cases, and it die out. So when you reach for the outbreak investigation, mostly you don't get it. So that was a scenario during 2009. That was also in the month of September. Few children had sudden deaths in Kandhamal district, of Odisha in Dwibedi area, and that is a high altitude area of Odisha that is called as Kashmir of Odisha with a altitude of around 4,000 feet, maybe more than 1 kilometer, 1.2 kilometer, height above this sea level. Normally, this area doesn't, this type of area is not a very good scenario for development of vector breeding sites like Phlebotomus sargentipes or sargentimia. So don't expect normally Phlebotomus will grow in this area because most of the cases like sandfly grow in the gangetic belts of VR or Uttar Pradesh nearby zones, and that is relatively humid nearby riverside areas are there. So people from Kaladar Institute of Patna, they have never seen Phlebotomus growing or identification in such a high place also. So, but depending upon the scenario, we thought that possibly it can be Chandipara virus encephalitis, and we proceeded to that situation, and we got around 21 samples investigated, and from there 4 samples are positive for IgM at NIV Pune. And here another difficulty of Chandipura virus encephalitis outbreak investigation is there is no commercial kits available. So we have to depend upon the NIV Pune kits, and the samples need to be transported to that lab and ultimately need a confirmation from that side. So I feel till now also many cases of Chandipura virus encephalitis is missing because we don't have proper investigation for this, and we don't suspect though it is supposed to be. Next slide. Next one. Okay. Uh, Fine. Next. Fine. If you okay, so here I try to put a table of a laboratory investigation approach that has been led by the team from NIMANS, Dr. Bhagirathi and many other virologists of the country has looked into this thing. They have made a scenario of which are the samples to be tested for which viruses and what type of investigation is possible in these cases. If you look into this chart, IgM antibody from serum or CSF remains as one of the diagnostic criteria besides PCR because many times you don't get it. And if you look into other samples like suppose in case of enteroviruses, we manage the getting a PCR positivity from CSF samples is not that high. It may be very specific, but sensitivity becomes low. So we have to depend upon a stool sample a collection to get enterovirus positivity, and we have to correlate the viral encephalitis clinical epidemiology so that we can say that this is because of enterovirus infection. Next slide. That means we need to choose a multiple number of samples, maybe serum, CSF, stool sample, or respirator sample. We have to combine all these investigations so that we can concretely say that encephalitis is because of this virus or it's not identifiable before saying it is what. And we have to take the consideration of the timing also when you are initiating the investigations and likely viremia, persistence, and likely antibody positivity. Next slide. Okay, next. Okay, we'll move. Okay, next. We'll skip. Next slide. Next one. Okay, fine. So this table is there. This publication is already there. We can look into that part. And if we see different viral etiologies, as I told, it's a difficult situation to really confirm whether acute encephalitis is because of virus or not. That means the viral etiology is not always evident, even if it is there. So we try to investigate more than 500 number of cases, samples from different parts of Odisha, including Cuttack, Bhubaneswar, and different district settings, district hospitals. And in spite of all investigations, we could get around 17.2% positivity out of 526 cases. That means maybe that we are missing many cases. So majority, at large, 17% were diagnosed. If you look into the causes for that, HSP or HSC 1 and 2 were the common one, then followed by the measles, Japanese encephalitis, dengue, varicella zoster, and enteroviruses. Though in the Western settings, we are getting many number of nestled. Enterovirus positivity in the Western world, we are not getting enterovirus positivity in a sufficient large number of samples, even if we suspect sometimes. Maybe that we are taking a delayed investigations, and enteroviruses kits are not good enough, are not available also in a good form, and only we have to depend upon a PCR sample from the CSF. And as I told, it's not that sensitive, though it is very highly specific, and majority of the times we don't process a stool sample also. If we look into the pattern of encephalitis cases throughout the year, most of the cases are occurring in between the September to October, November, that season. I told maybe we are combining HSP with vector 1 infections, or the season where vector 1 infections are more prone. Next slide. Next slide. Okay. You can see that all age groups are affected. All the children are affected, mostly below 5 years, and also above that, the elderly population also affected. Next one. Next. Okay, fine. Here. From those investigations, we tried to look into possibility of HSV and measles co-infections. Whatever samples we tested, in many cases we got a co-infection or double positivity, means measles positivity as well as HSV positivity. And we tried to look into whether these co-infections are double having a high morbidity or mortality. It was really evident that the longer hospital stay and GCS at the initial presentations or the persistence of low Glasgow Coma scale score was more in cases of co-infection, co-infected cases where measles plus HSV are dominant. It may be because of a immune suppression effect of measles. Either two things can be possible. When you get a measles infection, the latent HSV gets come to the surface, and both can manifest as a combined infection. But here there is some difficulty that we are not very sure. We cannot be very sure that whether both are causing encephalitis or not, or HSV encephalitis is dominant definitely, and measles is causing immune suppression only, and that is causing some degree of higher morbidity, or it is also contributing towards encephalitis. That remained not clear, but both possibilities are remaining. Okay, next slide. So as I told, the possible risk for HSV latent infection to surface can be because of measles infection. Another angle of this thing was acute encephalitis was investigated. Many times we look into some nitric acid pathways. We have neuronal nitric acid synthase enzymes. There are certain polymorphism related to that. That is NNOS gene polymorphism. And we have seen largely all these HSV infections causing encephalitis were having a polymorphism into it. So we possibly feel that there is a possible risk for HSV latent infection to come to surface if there is some other additional risk factors are there in this polymorphism group. So that may be a host factor is playing in HSV latent infection to come to the surface. So besides this additional risk of infection from outside, definitely there is a host mechanism to which patient will go towards HSV encephalitis or not throughout, even if HSV latency is there for a long period. Next slide. Next one. Okay, fine. Then other contributor remains actually a case of autoimmune encephalitis. As I told, out of all acute encephalitis syndrome cases, we are able to diagnose 17 to 18% cases, and in some centers like maybe PJ Chandigarh, CMC, maybe from CMC also. I don't know, very sure of it how much they are diagnosing, but I feel largely 20-30% cases are being diagnosed, even if we are putting too much effort into it. But can it be another angle like autoimmune encephalitis is a possibility or not? And is there any relationship with viral infection here or not? So we have done a study that included KGMU Lucknow and also Odisha site AIIMS Bhubaneswar and SCV Medical College Cuttack, where out of all the samples at UP and Odisha, we got 37 cases, that is around 4.2% showed autoantibody, especially NMDA. Other antibodies are not available, not seen, and 25 had a viral trigger also. That means out of all these cases which are having autoantibody, which we diagnose as autoimmune encephalitis, we have seen a viral trigger in 67% of these cases. Means viral trigger means especially HSV infection in form of a raised titer. Next one. Next slide. Okay. If you look to the table, the viral causes most common is HSV, which was around 45%. Both of the cases situations around 45 to 48%, both in UP and Odisha. And we got higher NMDA positivity from Odisha, not from in comparison to KGMU. I don't know exactly. We don't know the exact cause why it is so, or it is really statistically significant or not. You can't interpret from here, but overall, around 2.9% cases were having a cause towards autoimmune encephalitis. Next slide. Next one. If you can see here is a combined summary table of that, we can get both positives. That means a viral cause as well as a autoimmune or autoantibody presence can be possible in these cases. So we presume that a simultaneous viral infections or viral encephalitis can induce some degree of autoantibody response also. That I mean to say that it can be cause also for either exacerbation or a potentiator for autoimmune encephalitis. Or sometimes it can so happen after the viral infection subsides, after some days of viral infection, there is a autoimmune component or in form of post-infectious possibility. So that is remaining problem actually for these cases of viral infections. So what I say is this viral encephalitis cases can have a simultaneous autoimmune expression, or it can have a post-viral autoimmune expression. Next slide. So any case which is not recovering with a classical line or it taking a delayed recovery, we can think of another autoimmune component to it, even if we are getting a cause of viral infection very definitely. Here also similar study are done on viral etiology. That also showed around 16%, not more than 16% we could diagnose as a cause. But where we looked into morbidity and mortality of viral versus, next slide, viral encephalitis versus non-viral causes, you can see look into that the symptom. And if you look into the next slide, if you look into the symptomatology, next slide, if you look into the symptomatology of the viral causes and non-viral causes of encephalitis, definitely there are some significance in terms of paralysis and some degree of cranial palsies were more in encephalitis with a viral etiology in comparison to encephalitis without a viral etiology. And even the features of raised ICP were more dominant in cases that is presenting with a viral conformation in compared to non-viral etiology. Next one.
Sir, sorry to interrupt, but we are a little short of time.
Sir, it's finished
Yes,
only.
sir. Yes, sir.
Okay, done. Fine. Next slide. Next, you can move to next. Okay, fine. If it is not moving, only this is only summary slide. What we plan for evaluation, what we are saying. For each and every case, we go with a routine evaluation of all the tests. And if possible case, the second line, the most cases we can go for a CSF study, neuroimaging some cases, or EEG if it is required. So evaluation of autoimmune encephalitis that remains the third line, or other causes like invert errors of metabolism or some other causes we look into if it is not being diagnosed with our first and second line of investigation. Fine. Next one. Okay. I don't go into that. I will try to wind up from this, because what just in a summary what I say, whatever viral epidemiology or acute encephalitis syndrome cases or isolated cases as a sporadic form or outbreak form we are having, the diagnosis, complete diagnosis is not available. Many times we are missing many cases. Still, we have to put much effort to reach to the largest possibility as much as cases we can detect with a cause, and as much as outbreaks we are attempting to investigate, we can get some cause to it. It may give some atypical or typical presentations, but we need to focus on that classical symptoms and some atypical symptoms within the line of current scenario, so that we can make it as a wholesome approach to acute encephalitis syndrome. Thank you. Priyanka, almost done.
Thank you, sir.
Yeah.
Thank you, sir, for that giving that bird's eye view of acute encephalitis. We are a little and thank you for that those insights into the regional epidemiology. We have just one question. What is the role of imaging in the diagnosis of acute viral encephalitis?
Okay. Are you asking anything? Can you just repeat? Sound
Yeah,
is
what
still.
is the role of imaging in the diagnosis of acute viral encephalitis? Role of imaging, MRI.
Role of?
Imaging, MRI or CT scan?
Could not listen. Role of?
The imaging, MRI or CT.
Imaging. Okay, fine. Normally, in case of encephalitis, you don't go for imaging, because we largely depend upon the clinical symptomatology and the CSF but some, as I told, some MRI pictures can be specific with regard to the specific infections. J can give a certain presentation, HSV can give a separate presentation, but otherwise autoimmune also encephalitis can give sometimes different presentations in terms of MRI findings, but many times that are not very specific. So MRI doesn't give much idea with regard to etiology. Anyway, you have to go for this viral assays. If not getting, then classical findings related to J encephalitis or HSV virus, as I told, frontotemporal lesion or temporoparietal lesion are more affected in case of HSV, or J it can have extrapyramidal involvement is more, or like the autoimmune encephalitis also sometimes we get extrapyramidal or some other areas also involved. This type of patterns we can look into. Otherwise, routinely it's not required.
Yeah. Thank you, sir. Since we are short of time, I think we'll go ahead with the next talk.
Yeah. No issue. Thank you.
Thank you, sir.
Dr. Mayur can share your slides.
Mayur?
Yes, ma'am, I'm sharing.
Yeah.
Is it visible, ma'am?
Yeah, it is visible. Can you make it in slideshow mode?
Yes, ma'am. Yes, ma'am.
Yeah.
Am I audible? Can I start?
Yes. Yeah.
Warm good afternoon to all the panelists and attendees. As a part of this, the Climate India Project weekly webinar, I would like to share some of our institutional experience with neuromelioidosis, and why is it can be called as the great masquerader. It will be some case-based approach where I like to share some few of our cases. The first case is of a 36-year-old right-handed male who had no previous comorbidities. He presented to us with a high-grade fever with a history of headache for the past 2 months and left-handed weakness, hemoptysis for the past 1 month, and darted sensorium for the last 15 days. He had no any significant past personal or any surgical history. The fever was high grade, associated with some cough with expectoration, and he had taken some local medications for that, which improved. But once the fever persisted, he visited the local hospital there, and following which he developed respiratory distress, and he was diagnosed to have COVID pneumonia, and he was treated for the same. And once he was stabilized, the patient was discharged home. Followed by fever, about 3 to 4 days later, patient developed holocranial headache associated with neck pain with a VAS score of around 7 to 8 by 10, which used to aggravate on straining and bending forwards. However, not associated with any vomiting, loss of consciousness, seizures, or limb weakness. Along with that, patient also had multiple episodes of projectile vomiting. About a week later, after the onset of fever, patient developed complete left hemiparesis in the form of difficulty in holding the object in the upper limb and dragging of the foot while walking, which progressed over the next 2 to 3 days to severe weakness such that he was barely able to move his limbs on the left side, associated with some deviation of angle of move to the right side. Simultaneously, he also developed arteries in the sensorium in the form of fluctuating cognition and irrelevant speech with the family members. Gradually progressed with the loss of comprehension, violent behavior, and non-coherence word output. The patient was totally disoriented over the next 15 days. Following this, the patient was taken to AIIMS hospital with this picture of history and history. We would localize the following symptoms. To the fever was thought of mainly systemic, and holocranial headache was slight mainly due to the meningeal inflammation. And left hemiparesis was since it was dense, probably localizing to right internal capsule, and the arterial sensorium was due to raised ACP or multiple lesions in the brain. Also, with this localization and history, we thought of possible etiologies as it was a chronic meningoencephalitis with endarteritis, probably in the internal capsule, thalamus, or coronary data infarct, due to either TB or other bacterial infections, or any focal brain abscess or cerebritis in the thalamocapsular area due to the bacteria or fungus, or a cardioembolic stroke with the source of septic embolus secondary to infective endocarditis, or an autoimmune disorder since the patient had COVID about a month earlier, post-COVID vasculitis, post-COVID ADAM vasculitis, or demyelinating disease. On examination, patient was in adult sensorium and he had fever, and other vitals were normal with the respiratory rate slightly being high, and other general physical examination was normal, and other systemic examination was also normal. Coming to CNS examination, as I told, patient was altered, and cranial nerve examination revealed both the people were asymmetric and had left human facial palsy and left a complete hemiparesis. Power was about 1 by 5. All the TTRs were brisk, and left plantar was extensor, and also sensory pain was reduced on the left side, and also he had signs of meningeal irritation in the form of neck stiffness, and Kernig's was positive. He underwent inpatient evaluation. Patient showed anemia with a HB of 10.9 and total count of 10,660, and platelet was 3.52 lakhs per microliters. And patient's RBS was 94 and HbA1c was 5.4. Peripheral blood picture showed a normocytic normochromic anemia. His renal functions were fairly normal. Also, thyroid function test was normal, and liver function test was also normal. CSF showed cells of 4 with a protein of 32, and glucose was 120 upon 180. With this picture, a routine workup for fever and encephalopathy, that CSF for CBNAT and TPCR were negative, and scrub IgM and cryptocurrency antigen were also negative, and a rapid antigen test for malaria was negative, and also leptospira IgM was also negative. Additionally, we also got ECG, 2D echo, chest X-ray, and Montauk test also did not yield anything. Following this, imaging, patient underwent NCCT head on the first day of admission, which showed some hypodensities in the right thalamus extending up to the diencephalon and up to the right midbrain down. It showed hypodensity surrounded by an isodense rim. 2 days later, patient underwent MRI. The actual T2 and flare MRI, as we can see in the image, it showed the hyperintensity in the same region of thalamus. The hyperintense score surrounded by a hypointense rim, which was extending up to the right diencephalon and up to the midbrain. It is extending on both sides, slightly more on the left more than right, right more than left, and also in the we had some lesion in the left temporal lobe also. We can see the core of the lesion was diffusion restricting, and also T1 and T1 contrast shows hypointense lesion in the right thalamus, and these lesions were contrast enhancing. That you can see the multiple ring enhancing lesions and those regions in the thalamus were conglomerate, and also we can find some satellite lesions in the midbrain as well, and also one ring enhancing lesion in the left temporal lobe. So this is the coronal section of the same patient, which shows the extent of the lesion right from the right thalamus extending and all the way down up to the midbrain, and also with its mass effect, it is significantly mass effect, so that it is pushing the midline to about 1 centimeter to the left, and also it is extending laterally up to the insula, and also it is extending up to the right lateral ventricle. With this ring enhancing lesions, we got the proton MRS of the same, which showed the increased lipid lactate and choline peak. To find the extracranial manifestations, we look for CCT thorax abdomen, which was mostly normal except for some right paravertebral collection. So the course of the hospital stay was on the day one with the history and imaging, we had thought of tubercular abscess, brain abscess, or fungal abscess. Empirically, patient was started on ceftriaxone and ATT with steroids. On day 4 of admission, patient had further deterioration sensorium with recurrent GTCS and sepsis. And patient had to be intubated and put on ventilator support, and the antibiotics were applied to injection meropenem, and empirically amphotericin B was also started in taking the fungal abscess. Further deterioration sensorium occurred on day 9 of admission, where patient subsequently developed hydrocephalus, and it had to be decompressed with the insertion of EVD. And further, on day 12 of admission, doxycycline also was added. By that time, all the routine workup for fever and also the first blood culture was negative. Further, patient deteriorated in the form of patient developed decerebrate posturing with some non-motor seizure episodes and severe dysautonomia in the form of severe sweating over the right half of the face. And on day 15, patient underwent tracheostomy as we could not wean him off the ventilator, and EVD was removed after 7 days. Further, there was no any improvement in the sensorium. On day 16, the second blood culture showed the growth of Burkholderia pseudomallei. Following this, patient was started on imipenem and cilastatin, and steroid was stopped. That time we were not aware of the infection much. Once we got the culture positive, we reviewed the literature and started him on the treatment. And once the treatment was started, patient had a decrease in dysautonomia and non-motor seizure episodes. Therefore, thereafter, about 2 weeks later, patient had a gradual improvement in the sensorium. There was no further seizure episodes or no dysautonomia. This was the repeat CT done, that is after 28 days of admission, which showed decrease in the lesions over the same regions of right thalamus, encephalon, and up to midbrain. You can see the lesion load has slightly decreased. That is in day 62, about 42 days after the admission of the initial admission, we can see the lesion on the right thalamus extending up to the midbrain. It has significantly reduced and its mass effect has come down. So this was the initial clinical photograph of the patient. This was 6 months later when the patient was, though he could not handle all his activities of daily living independently, he required some support, but patient had improved significantly from the time of presentation. He had so much disability and recovery was so late that we had to give the maintenance therapy of cotrimoxazole for up to 2 years. This was the photograph after 1 year and 3 years of follow-up respectively. So the MRI brain was repeated once again after 8 months. It showed there is almost resolution of the complete resolution of the lesion with some residual post-infective gliosis over the right thalamus. We can see rest of the brain was normal. So coming to second case, it is a case of a 53-year-old diabetic female who complained of headache for the past 2 months with fever and seizures. And she had no other significant past personal or family history. Headache was subacute in onset, severe headache of vascular 7/10, holocranial with neck pain, not associated with any vomiting or blurring of vision or sense of raised ACT. Fever for about 15 days, high-grade chills and rigors. And just before coming here, 5 days back, she had one episode of GTCS lasting for 5 minutes. When she came here, she had no any fever episode. Patient was confused. Patient was conscious and oriented, and vitals were stable with normal general physical examination. The renal nerve, motor, cerebral, and sensory examination was normal. She had some meningeal signs in the form of neck stiffness, and the chronic signs was positive. So, and again, she went inpatient evaluation at AIIMS, which showed anemia with a HbA of 8.1. Total count was fairly normal, 7,000, and she had uncontrolled diabetes with 8% HbA1c, and CRP was elevated to 67, and sodium was slightly low, 129. CCT abdomen was done, which showed heterogeneously enhancing lesion in the right lower kidney of sensitive of abscess, and MRI brain was done on day 2, which showed diffuse pachymeningeal enhancement along the entire right cerebral hemisphere. It was also present on the left side, but right side was slightly more on the left side, with the focal leptomeningitis in the right frontal region. Also, the CCT thorax showed some pretracheal and hilar lymph nodes, which are heterogeneously enhancing due to necrosis. So the investigation further continued. The initial CSF showed 7 cells, which were 100% lymphocytes. Protein was 92 and glucose was 83.6. And other workup for cryptocal antigen, KOH mount, CBNAT, TB-PCR, and bacterial culture was negative. And ANE profile, ENCA, Sianka, Pianka were negative, and also serum IgG4 levels were also normal. Then the second blood culture and also aspirations from the necrotic hilar lymph nodes and pretracheal lymph nodes showed the growth of Burkholderia pseudomyelai once again. That is, but the renal abscess finis did not show any growth. So this patient received the intensive phase therapy of meropenem for 2 months in hospital itself, and thereafter she was given the maintenance therapy of cotrimoxazole for 6 months. The patient was almost symptom free from the day 10 of admission itself, but we followed up for 6 months and received full treatment. This was a third case is of a 17-year-old male student who presented to us with a 10 days history of fever, followed by headache, right hemiparesis, and right lemon facial palsy, and dysphagia for 3 days, and acute onset left upper limb weakness, diplopia, and also left side hemiataxia, and followed by right upper limb weakness for the past 1 day. On examination, sensorium was normal. He had multiple cranial neuropathies in the form of bilateral horizontal gaze palsy, bilateral element facial palsy, absent gag with 9th and 10th nerve palsy. Also, bilateral sternocleidomastoid and trapezius were weak. And also, he had right hemiparesis, and left upper limb was slightly more weak than the right side. Sensory examination was normal. He also had some meningeal signs in the form of neck stiffness. His routine investigations were normal. CBC, liver renal function tests were normal, and also viral serology was normal. On day 16 of illness, we got the MRI brain, which showed hyperintensities mainly in this is the flare actual sequence of MRI, which showed hyperintensities mainly in the right near the center sulcus, right frontal region, which is extending up to the bilateral right internal capsule, and also up to the midbrain and up to the dorsal pons. We can see the hyperintensity of the bilateral dorsal pons slightly more on the right side as compared to left side, and also we can see the enhancement. The down panel shows the T1 contrast images, which shows the enhancement of the right trigeminal and facial nerve, and also this is the cital section showing the extent of the lesion starting from the midbrain up to the extending up to the lower pons and even up to the medulla. So this was the spine imaging, T2 and T1 contrast imaging of the spine. You can see the extent of the lesion from the pons extending even below the medulla up to the higher cervical cord up to C7 region. And the T1 contrast, we can see nodular linear contrast enhancement at the C5, C6 level. Also, axial section showing the burden of lesion slightly more on the left side as compared to the right side. So outside, before coming here, patient was evaluated with his CSF showed 2 cells with a protein of 119 and glucose was 55, but they could not isolate any organism from the culture. After coming here, the inpatient evaluation, the CSF showed 18 cells, 100% lymphocytes, protein was 58 and glucose was 59 upon 118. The routine blood and urine culture showed no growth, and also other workup for leptospira, scrub, Brucella IgM were also negative. Again, ANA and ANC profile was negative, and CSF viral panel for JE, HSV, CMV, VZV was negative, and also CSF CPNAT, KOH, and fungal culture also negative. Pathology test in view of Bechet's that was also negative. Also, NMO and icoporic 4 and MOG antibodies were negative. Also, since patient had multiple cranial neuropathies with the quadriparesis, we also had thought of GBS and variants. So, ganglioside antibodies were sent. That was also came out to be negative. So, the hospital course of the patient was we had started him on IV antibiotics empirically with vancomycin, amikacin, and ampicillin. And despite that, patient had poor respiratory pattern and had to be intubated on day 2 of admission itself. That is day 12 of illness. He was given with 1 gram of methylprednisolone for 5 days, thinking it to be inflammatory etiology, followed by IVIG for 5 days. Patient did not improve. Patient still had continuous fever and antibiotics were upgraded to meropenem. In view of prolonged ventilation requirement, patient was tracheostomized. And after upgrading to meropenem, patient gradually responded to the treatment. He became afebrile and was weaned off from the ventilator. Then patient's facial weakness, dysphagia, and asymmetric quadriparesis improved mildly, but with some persistent weakness on the left side. Then finally, patient was decannulated on day 43, and he was decannulated on day 43 for tracheostomy. So repeat MRI was done on day 45 in hospital itself when the patient before discharge. which showed almost complete almost resolution of the lesions which were present earlier in the right high frontal region, and also in the right pons lesion, frontal lesion, we can see it has significantly reduced. Left side it has almost disappeared, and also the spine lesion which was present from the lower medulla up to the C7 cord, also it has reduced significantly. So with this clinical and radiological improvement, the patient was thought of the infection triggered demyelination, probably acute demyelinating encephalomyelitis or AIIMS, and he was discharged with this provisional diagnosis. So was that the end of the story? Unfortunately, no, because the patient visited us again after 10 days with a history of high-grade fever, continuous fever with the sudden onset left hemiparesis. This was onset peak was very fast with the severe weakness of 1 by power on the left side, 1 by 5 power on the left side, and also along with that patient developed right hemiparesis 2 days later and severe truncal weakness, and patient was bedbound. So again we were in dilemma. With this, again we had to work up. The second time CSF study after the second visit showed us 2 CSF cells with a protein of 61 and glucose of 70 by 107. The blood culture, this was the third blood culture. Again it yielded, it was negative, and again once again the CC thorax symptom was repeated. It was again turned out to be normal. So on day 63, that is day 63 of symptoms, that is after 12 days of discharge, again one more MRI was repeated, which showed again the hyperintensities in the right high frontal region, and also extending up to the right internal capsule and basal ganglia, cerebral peduncles, right midbrain, and up to ports. All the lesions which were present before were also now slightly increased with some new lesions. And also there was we can see the T1 contrast, the images are taken with the patchy contrast uptake, and also we can see the enhancement of the fifth cranial nerve. This is the sagittal section and coronal section of the image, T2 and T1 contrast. We can see the extent of the whole extent of the lesion starting from the cortex near the precentral gyrus up to the subcortex, internal capsule, coming up to the level of midbrain. And this we can see the tracking sign right from the cortex along the white matter up to the midbrain. So also this was the corresponding FDG PET of the same patient, which showed the tracking of the hypermetabolism along the length of the white matter tract, that is from the cortex up to the midbrain. So with repeated blood cultures were negative, and also the CSF and blood PCR for melioidosis was thought from the previous literature, that also came out to be negative. So since this was negative, and clinically and radiologically, we made a provisional diagnosis of a probable neuromelioidosis, and the treatment was started with intensive phase meropenem for 2 months, and for him the maintenance therapy for cotrimoxazole had to be given up to 1 year. So this was the initial photograph of the patient on day 13, and after 8 months, the patient had almost significantly improved with some residual disability in the form of spasticity bilaterally. So summary of just fourth case is a 70-year-old male, uncontrolled diabetic who had 1.5 months history of fever, headache, altered sensorium, weakness of all 4 limbs, and altered sensorium for 10 days. On examination, patient had a GCS of E1, E1, M4, and spasticity in the both upper and lower limbs with quadriparesis with bilateral plantar extensors and meningeal irritation signs. So this was the MRI on admission. This was MRI done outside actually on admission, which showed bilateral T2 flare hyperintense lesion in the bilateral thalamus, bilateral bifrontal region, left thalamus, and corpus callosum, which showed some distinction. And T1 contrast is showing the conglomerated lesions in the corpus callosum and right temporal and frontal regions with significant vasogenic edema. So the hospital course of the patient was provisionally with this history, 1.5 month history of fever, altered sensorium, and quadriparesis. Chronic meningoencephalitis with multiple brain abscess with mild septic shock was made, and unfortunately, patient succumbed due to severe sepsis on day 2 of admission itself. But after that, after taking the consent, we went ahead with brain biopsy, and we aspirated the pus, which was sent for culture. This was again sent for culture, which revealed Burkholderia post-mortem. So neuromelioidosis is caused by Burkholderia pseudomyeli, which is a gram-negative bacillus, which commonly infects the lungs in the form of pneumonia. The brain infection is reported to be less than about 5%, 3 to 5%. The infection is predominantly seasonal, with 80% of the cases occurring mostly during the rainy season in those who are in frequent contact with the soil and water and immunocompromised patients. Modes of infection are mainly percutaneous inoculation, inhalation, and the ingestion of this contaminated food or water. They have tendency to inoculate the olfactory bulb and then spread to the central nervous system, or due to the infection of the nasal mucosa, and they invade through the ophthalmic region of trigeminal nerve and then spread into the brainstem. So this is the current global burden of neuromelioidosis, which is more prevalent in the northern part of Australia and the whole of the India, China, and Myanmar, and in few states of Africa, South America, and also lower part of North America as well. From head to toe, the signs of melioidosis can affect any organ. As I told earlier, the most common being the lungs, liver abscess, spleen abscess, and also soft tissue abscesses, and also brain infections, which was less than 5%. Also, the scrotal abscess, septic arthritis, muscle inflammation, pareintestinal mass, etc. So, in our country, the highest case series was published in 2021 from CMC Vellore. It was a retrospective case study in which the authors compared the lesion-specific involvement of neuromelioidosis with previously published literatures. This was in that they showed that there was more than one set involvement in 13 patients out of 18, and 5 patients had pure parenchymal involvement in the form of early and late abscess with multiple lesions, and also 8 patients had various osteomyelitis, and 6 had epidural and dural abscess, and leptomeningeal enhancement was in 8 patients, and other extracranial involvement in the form of orthomastoditis, nasopharyngeal collections, musculoskeletal collections were seen in other patients. So in 2023, there was a paper on cranial MRI findings in neuromelioidosis published from our department in 2023 in Neurology, India. Here, the authors had reported 6 culture-confirmed melioidosis cases from our center from 2020, from 2021 to 2023. Out of them, 4 had brain abscess, 1 had meningitis, and 1 had a spinal epidural abscess. Also, they emphasized on the imaging typicality, like extension along the white matter tract or neurotrophism in 2 patients, and also the MR spectroscopy characteristics of neuromelioidosis, like the lipid lactate peak and choline peak, and its and how to differentiate them from TB. Also, there is a recent case series from South India, from Madurai. They have reported 13 cases of culture confirmed cases of neuromelioidosis were published in Indian Journal of Medical Microbiology this year. And also, there was a recent outbreak in Tamil Nadu from the year 2020 to 2023. 21 cases of neuromelioidosis was identified in just 1 year. Out of them, 11 cases were sporadic, and 10 were mainly related to the prior dental exposure in a dental clinic. So, in this, the authors identified the gene, that is BIM ABM gene response, which was associated with neurotropism, and was responsible for the outbreak, and also the strain they identified as ST1553 strain as the major cause of this outbreak. So this 2022-23 Tamil Nadu outbreak provides one of the strongest epidemiological examples supporting the direct transneural neuroinvasion by Burkholderia with the prior dental exposure and contaminated saline. This was actually they emphasized that here in dental clinic the saline was being opened by an unsterile periosteal elevator, and it was being washed in a tap water. So they identified that as a potential source of infection and cause of the outbreak. So coming to the management, CSF shows lymphocytic pleocytosis just like TB and elevated protein. And imaging, it is a rapidly progressive abscess. And some of the typical imaging findings of neuromelioidosis include the center of the lesion on T2 weighted image appears hyperintense as against hypointense in caseating TB. And also they have tendency to form multiple microabscesses, and the tendency to extend along the white matter tract is called tunnel sign or neurotrophism is well identified in melioidosis along with sparganosis and hysteriosis. Also, its tendency to inoculate along the trigeminal nerve and its nucleus involvement, followed by other cranial nerves like 7th and 6th nerve. Also, the culture still remains a gold standard for diagnosis. The melioidosis actually grows well on any culture media like blood agar, McConkey agar, chocolate agar, but the specific medium is Ashton's medium or modified Ashton's agar. The tunnel sign is a tubular enhancement, linear or linear pattern of extension of the lesion, which is unusual appearance of brain abscess. Mainly, it is caused in Burkholderia pseudomallei or Spirometra mansoni, which causes sparganosis, and also Listeria monocytogenes producing brainstem encephalitis. So this is the classical images showing the tunnel sign, where we can see the coalition of multiple microabscesses. Also, we can see in the F and H images, where we can see the tendency to spread along the white matter tracts. The H image, we can see the lesion spreading or extending along the corpus callosum. Also, the melioidosis requires long-term treatment. The treatment mainly consists of 2 phases: intensive phase, which requires IV antibiotics for 8 weeks with ceftazidime and carbapenems like meropenem, Also, maintenance phase with cotrimoxazole, it's given for 6 months. However, the 6 months is not fixed; it is individualized based on the severity and recovery of the patients. So this was the revised Darwin guidelines of melioidosis for treatment, depending upon the various sites of infection. CNS infection requires about 8 months of intensive phase therapy and a minimum of 6 months of eradication therapy of 6 months. So, next, running through the our institution experience in neuromelioidosis, that is, we have till now about 12 cases of neuromelioidosis, out of which 9 were culture proven or isolated organisms. We have gotten 9 cases from about 2020 to 2025. And 4 of the patients had succumbed, and the rest of the 8 patients improved. Among them, 6 of the patients had extracranial manifestations in the form of liver abscess, splenic abscess, kidney abscess. So other contributions from our institution, that is like a clinical handbook on clinical melioidosis, that is a practical guide to diagnosis and management, was published from our institution. In this chapter on neuromelioidosis was authored by our department and the authors from Department of Radiology of our institution. Also, recently we also have published the utility of a novel imaging technique called the gallium-FAPI 46 PET-CT imaging in neuromelioidosis. This is a case series basically demonstrating the potential utility in the diagnosis of neuromelioidosis. It can be used in other infections also, and its superiority over MRI in showing the early recovery of the lesion or response to therapy. So the take-home message or running points is that the neuromelioidosis is not a uncommon differential of abscess or meningoencephalitis. Its potential diagnosis by the typical imaging findings it has. Always the blood culture or serum culture is more sensitive. Also, when we don't get the culture positive, we should always consider the biopsy from other peripheral organs. Or always, it has a long treatment course, which can make a significant difference in the prognosis of the patient. Thank you.
Thank you, Dr. Mayur.
Yes,
I would request Professor Bhoi to give his insightful comments on this and on his experience.
Thank you, Dr. Priyanka. Thank you, Climb India team. Am I audible?
Yes, sir.
So both the topic Dr. Dwibedi sir and Dr. Mayur has described. So the AES, it's a more of a challenge. It's a national challenge for the infectious diagnosis. And now the mimicker is the autoimmune encephalitis is coming. So the entry criteria is 5 to 7 days of fever, or within 10 days of fever should be there. And slightly the autoimmune, they have slightly more prolonged course, but we can get sometimes the very acute presentation also. And secondly, the imaging for encephalitis, for a neurological perspective, we depend on the imaging, not only to rule out the other differential diagnosis, but to rule out in specific causes of imaging characteristic of certain encephalitis, like the HSV encephalitis, bilateral temporal asymmetrical basifrontal, and the classical of the JE having bilateral thalamic lesion, and certain brainstem encephalitis. So imaging, preferably the MRI is more helpful as compared to the CT scan, and to rule out other etiology like a focal deficit before going any other intervention procedure. Because in our area, the most common is the tuberculosis for a subacute presentation. So melioidosis is we like to give more threshold because it is a re-emerging disease. Earlier we have seen certain case report, but now they are getting more number of neuromelioidosis cases or melioidosis cases because of our awareness and the diagnostic utility, and now we are getting more of a rapidly diagnostic test like the PCR, and you can isolate the organism by the other quicker method. So the thing is that in a subacute presentation like a TB presentation, in our all the 4 cases prototype we have seen, the boy who presented very acutely within 10 days, we have missed the case. Initially, we thought of ADEM. We could not diagnose that melioidosis. All these cases were during the immediate COVID era. At that time, we were newly seeing the melioidosis cases and the neuromelioidosis, and we were not equipped to diagnose all these things. Gradually, our lab support started. The imaging, they were more acquainted with the diagnostic criteria, and they now quickly pick up the cases. So only thing is that once you see more number of cases, try your differential diagnosis, then the chance of picking the diagnosis is more. So in case of neuromelioidosis versus tuberculosis, for a neuromelioidosis, if you get multiple abscess, punctate lesion, abscess, division restricted, contrast enhancing lesion, may be coalescing, may not be coalescing. but they should track along the white matter tract, either through the projection fiber like corticospinal tract or a commissural fiber going to the other side of through corpus callosum, and sometimes they reach up to the brainstem area. So if you get this type of presentation, and chance of getting neuromelioidosis is higher than the tubercular CNS infection. They can present with meningitis, encephalitis, spinal cord lesion, abscess, anything that can mimic of tuberculosis. Second thing is the cranial nerve lesion. Suppose if you see any fifth cranial nerve, seventh cranial nerve lesions or hyperintensity or contrast enhancement, chance of getting a melioidosis is higher than a tuberculosis. So these are the two things. Tunnel sign, different signs are there. They are for only for more of a theoretical purpose. But if you see meticulously the micro abscesses and they are tracking along the white matter tract, then your chance of getting a melioidosis is high. But the sensitivity of the culture and other in CSF, chance of getting culture positive is less unless they are antibiotic naive cases. But in India, over-the-counter antibiotics, somebody will give some antibiotic. So you have to search for the other site for the abscess, like a solid organ abscess, spleen, lung abscess, liver abscess, kidney abscess. If you are getting any abscess in the peripheral organ, try to aspirate and send the culture, and chance of getting the culture is more. They are predominantly by hematinous spread, sometimes from the fifth cranial nerve or the seventh cranial nerve. So if they are getting a brainstem encephalitis with a micro abscess, so isolated, that may be due to the cranial nerve. Through that, it is passing through that. So only thing is that all these cases are that once you are more aware of the cases, then chance of missing is less, and you can quickly diagnose, because the outcome is not so rewarding, because you have seen all these three cases, they have much disability, and we have 4 patients who have lost them because of the delay. At that time we thought of TB, antibiotic given, they could not come out. So this was the case, and sometimes they have very rapid presentation. One patient died within 72 hours, where the biopsy was done in that patient. So this was our experience. So over to you, madam.
Yes. Thank you, sir. That was very wonderful. I think you're seeing a very high burden of melioidosis, and in fact, melioidosis we are actually seeing mostly in the coastal regions. So I think Bhubaneswar makes it a very ideal location because in the coast. Especially what they say is in the coastal and a lot of tropical areas, there is a continuous high soil. The concentration of the organism in the soil itself is very, very high. And that's why we are seeing a big pocket, Orissa, then even Karnataka adjoining the west coast, we see. And we do see a lot of cases in Tamil Nadu as well. But as you go to the temperate and the arid regions, we hardly see many cases. So I think it's a very fantastic, both the talks were very good and educational. There are a couple of questions on milioid. So in India, what is the rate of trimethoprim sulfamethoxazole resistant strains? And is probable neuromelioidosis an acceptable terminology as diagnosis? So, sir, would you like to answer out of or
Okay, madam, because we have not taken the sensitivity pattern of the trimethoprim sulfamethoxazole. So whatever thing is there for acute therapy, we have to give the carbapenems and the ceftazidime, the cephalosporin. There is the drug of choice for minimum 2 months. And in case of severe illness, sometimes the patient is on a ventilator, we can extend up to another 1 month till the patient is stabilized. But the guidelines is 2 months of intravenous therapy, followed by the maintenance therapy with trimethoxazole sulfide drugs, the Bactrim DS. Bactrim DS. So, but we have no idea about the resistant pattern. In the first case, we have given almost more than 1 year to that patient, and gradually the patient settled down. So the question for the resistance, actually, we have not gone through this.
Yeah. So
probably. Okay,
in our institute, our rates of Bactrim resistance is very, very less. In fact, there is the concept of resistance to any of these first line drugs has not yet come to, at least in our center. I'm not sure about the other centers which have very high concentration, especially in Manipal. I've heard they had some resistance to ceftazidime, but not to Septran. And the probable neuromelioidosis. So in epidemiology, in fact, in our article also, we have actually mentioned as probable because the cultures, as Boyce correctly said, the yield of cultures is extremely poor, especially in neuromelioidosis, because one, it is intracellular, and two, only the tissue has the highest concentration, and it's very difficult to do an invasive procedure just for the sake of getting a tissue diagnosis. Especially all these abscesses are deep seated, either in the brainstem or in the thalamus, which are all critical areas which we cannot actually do an invasive procedure just for a diagnosis. So that is why this term of probable neuromelioidosis, where you have the compatible presentation like a brainstem syndrome, and like Sir rightly said about the characteristic imaging findings, microabscesses, punctate enhancement, and of course the tunnel sign. So if you see that, you can label them as probable and start the empirical therapy. So as they respond, you will know you're in the right. Anything to add on, sir? Boy, sir, and
yes, madam. Because the culture from the CSF is very less, yield is very less. So unless you target the tissue, as you rightly said. So sometimes we tell our resident to screen the whole body, the CCT, thorax, abdomen, to look for any other solid organ where you can easily go for a FNAC or biopsy, whichever is possible. So that area can give the chance of that the CNS region is due to the systemic melioidosis abscess with a brain involvement. And for a confirmed neuromelioidosis, the isolation from the CSF of brain tissue is required, but that is very difficult.
So other thing about intensive therapy is in our center, we actually target the radiology and actually continue the intensive therapy. And we do a combination. So we give all three drugs, doxy, Septran and Miro in the beginning itself. We hit hard because all three drugs have different mechanism of action. On the one acts on the cell wall of the bacteria, other acts on the Golgi apparatus and the nuclear part, and other has both dual action. So in fact, we harness all those three, which we found it actually helps compared to just isolated monotherapy. So there's
Yes,
a third.
madam.
Yeah, so
Also, we also follow that same thing because anyhow the patient will get a doxy because of AS syndrome. Secondly, we add on the trimethoprim sulfaceptran because sometimes only meropenem
might
we
not
are
be
not sure by the time we get the report. And
Yes.
in one case, we have given both the drugs also, ceftazidime and meropenem, because it was very critical.
Yes. So second question is, the Australia, Southeast Asian strains grow early on culture. In India, prolonged incubation is recommended. What is the reason? So, sir, would you like to take on?
The thing is that the Burkholderia pseudomyeli, they are very slow on the growth. But if you give probably the enrichment media is more better. And what is the cause for the prolonged incubation? We have no idea because our specific strain.
That's what is the reason. So because it's an intracellular organism, and it needs an enriched media for growth. So in fact, in our experience, if you actually send tissue or CSF, it doesn't grow. But what we do is, you have the Bactec bottle where we inoculate the CSF and send. In those cases, actually, we have found at least 50% growing. So in fact, that is an important observation that we have found in our experience. So, and prolonged incubation is the rule. I don't think in Australia and Southeast Asia also, the dominant strains take time to grow. It's usually the average median time period is about 4 to 5 days from the time of inoculation. So it's a uniform dictum that you have to inform the micro to inoculate it and keep it incubated for a longer time for it to flag. What is the experience of doxy maintenance in terms of prognosis in non-neuromelioidosis? So, Dr. Priyanka, Dr. Mayur, you can take the doxy maintenance therapy in terms of
in most of our cases, actually, since these patients present with febrile illness, so doxycycline was given in the initial part as a part of the acute encephalitis protocol. And but for maintenance, the usual drug, the same goes with us also. It is The duration of the intensive phase depends on a case-to-case basis, depending on the clinical response and on the radiological response. And the usual drug that we use is meropenem and cotrimoxazole. And the drug that is used for maintenance usually is cotrimoxazole again. And I don't think we have used doxycycline as a maintenance in any of our patients with melioidosis.
Madam, okay.
Yes, sir.
But
Yes, sir.
the current CDC guidelines, it mentions doxycycline and also amoxiclav
One
as
of the potential drugs.
alternatives for cotrimoxazole. But doxycycline, since the cotrimoxazole is easily available, so everybody usually goes with cotrimoxazole. If it is not tolerated, we can go with either amoxiclav or doxycycline as an alternative.
So in our center, we have a couple of patients who are allergic because sulfa allergy, and in fact, some had developed even like almost skin and interstitial nephritis with Septran. So in them, we didn't have an option but to give doxy. But even if they tolerated the Septran, we still added on doxy because doxy, most of the isolates are actually sensitive, and it's a totally different mechanism of action. So targeting the bacteria with different mechanisms also helps, especially in critically ill patients. Bhoi sir, any comments?
Yes, ma'am. For all the guidelines is the Septran or the trimethoprim sulfamide, but if you give for 6 months to 8 months, long duration, sometimes they do not tolerate. So in certain cases, you have to switch over to the amoxiclav or the doxycycline. They are also, but the thing is that they are the second line. So second line is always second line. The evidence is on the first line. So if not tolerating, you can switch over to the second line, and you have to follow this patient more meticulously for any recurrence of symptoms.
And one more important thing is what we did in our center is we also do the therapeutic drug monitoring when you have the facility to check the Miro level in the blood. So what we did was we targeted 3 to 5 times higher value in the blood, because whatever crosses over to the CSF is, if you have maintained 3 to 5 times higher in the serum, your CSF level is adequate. That's the dictum. So in fact, that also helped, especially because there are deep-seated abscesses. Maintaining a steady state in the CSF is also very important.
Okay, so the MIC level you have to maintain more than 3 to 5 times the minimum concentration in the serum.
Concentration
so the
of the MIC
level is high.
Yes. So that we have done it for a few patients. We are just compiling those. In fact, all of them have done very well. And some we actually followed the guidelines and we stopped the parenteral in 8 weeks. And they have 2-3 have relapsed. The moment you stop, they're well for 2-3 days and then they start developing fever and imaging becomes worse. In fact, one lady went on, became hemiplegic. So what now we are doing is we are targeting the radiology. So till the contrast enhancement disappears, we actually give the parenteral. In fact, there are patients who even took 3 to 4 months of meropenem. Or like every week change the PIC line and give it. So because it's very risky when they relapse, it's like 10 steps behind whatever progress they've made. So that also made a difference.
Yes, ma'am. In case-to-case basis, you have to go for a prolonged course of IV antibiotics. But for other organ like lungs, that is very easy to manage. But for the CNS or the bone melioidosis, that is difficult to till we get a adequate removal of the bacteria from the tissue. So difficult to. So rightly say, if you get a contrast enhancing lesion, till you can continue the IV antibiotics. And rightly you said, madam, the type of how you are sending the sample to the microbiologist. If you send in a plastic bottle, the CSF, plain CSF, chance of getting the bacteria is very less, unless you send in a bacterial bottle. So if you send that will get amplify that.
Yes.
Thank you.
So I think that's about the questions. So any other comments from the panelists?
I think there's one question on the meropenem dosage and neuromelioidosis. Dr. Mayur, would you like to answer that?
Yes, ma'am. The recommended dose is usually 1 gram hourly for 8 weeks. If in case of any severe infections, it also recommends we can grade up to 2 gram hourly for 8 weeks.
So we
actually individualized.
Yeah,
Yes.
so that's individual. That's the correct thing. So what we actually start off with 2 grams. That's the meningitic doses, 2 grams Q8 hourly, and we prolong the infusion, because if you see Miro curves, it actually moment you infuse, it reaches the highest peak and then it drops. So if you want to maintain a sustained level, you give it as an infusion over 4 to 6 hours. So that maintains a steady state Miro concentration. So, in fact, some patients, after doing this therapeutic monitoring, we have even hit the doses of 4 grams Q8 hourly, at least for the first 2 weeks. So, it looked scary, but they don't end up with toxicity because there's so much of abscess and need, it gets absorbed, and they've all done well. So, so I think it's like you said, it's an individualized, like Bhoi sir also highlighted, it's an individualized precision. It's like more TB type of management. So in TB, again, no 2% gets the same steroid dose. Some needs high, some needs low, depends on the response. Any further discussions?
There's another question. I think we have actually incited a lot of questions. Any trial on ceftazidime avibactam on ATM, I think, therapeutic monitor for melioidosis?
Okay, Astronam. Okay, so ceftazidime Astronam for melioidosis. I'm not aware of any trial. In fact, even this Miro and ceftazidime itself, there is no trial. It's only case series which people have given both, and they compared and they found Miro to be superior. So, as of whatever I know, at least till 2 months back, there is nothing published about ceftazidime Astronam.
Yes, madam. For Estionam, this is the newer antibiotic.
Newer antibiotic, yes.
So we have no experience on the combination of Septa Estionam or Mero Estionam. We have no experience. Okay, so probably all the questions were answered. So, madam, you can take over the mic and conclude.
Yes. Yes, sir. So thank you very much, Bhoi sir, Dr. Priyanka, Dr. Mayur, and Dwibedi sir. It was a very very, thought-provoking discussions, especially neuromelioidosis is an emerging infectious disease. And I think spreading the knowledge on the radiological findings is very important, because you need a good lab to, suspect it and, identify it, and and in debate, and most often the culture positivity in our lab also, it's around neuromyelitis is only about 15%. So the remaining actually goes undiagnosed. It's mostly probable. So these are the take-home messages. Thank you, team at AIIMS Bhubaneswar. Thank you, sir. Thank you, Dr. Priyanka Mayur, for the wonderful talk. So we'll meet for the next webinar, which will be next month, which will be on amoebic meningoencephalitis. Thank you all.
Thank you. Thank you, ma'am. Thank you.
Thank you. Thank you, ma'am.
Thank you.
Yeah.